Here's another uterus. Looks like we're expecting to see some adenomyosis here. The minute we inject a tiny amount of fluid, suddenly a collection of little micro foci, bright reflectors appears, what we think is air that might have been in the catheter, and this was absolutely not present prior to the installation of fluid. We have found that that we can actually fill some of these cystic spaces during the sonohysterogram, as happened in this patient. There was no fluid here, and then here's the myometrial crack, and then filling of this space. So in those other cases, we think that the micro air bubbles escape through these little tiny cracks into the myometrium. This is another patient that had absolutely no cystic changes, but after filling the cavity, there was fluid filling a little outpouching with a connection with this crack in the myometrium. Another example here of a patient with a focal adenomyoma. Here, a heterogeneous rounded area, no real mass effect, blood flow throughout the mass. And as we started filling, we have bright reflectors that suddenly occur, and over the course of time, fluid shows up in the wall. So there must be some little small connection that is allowing this fluid to fill. In some cases, it may be impossible to distend the cavity, especially if it's been scarred. And sometimes it's the air that actually may help you during the sonohysterogram. This patient had postmenopausal bleeding, and when we instilled a little bit of fluid, we could not really distend the cavity, but a little bit of air was able to find its way, and we were trying to delineate the endometrium, but realized that suddenly this was actually filling a larger area of myometrium, showing little tracts of how this air escaped and infiltrated here into the myometrium, proving to us, we think, that there were connections with the endometrium and infiltration with adenomyosis. Now, there was no force applied here, absolutely at all. This patient certainly wouldn't have even allowed that. And we have this distribution of air then throughout the myometrium as a sign of adenomyosis, which, by the way, was proven in this case with MRI. Congenital anomalies, we can introduce fluid into the cavity. Here we can see, this is in conjunction with 3D from Dr. Anna Leftoff, loaned me these cases, where we have fluid filling one horn and not the other horn in this patient with a long septum that separated the two cavities. Another patient where fluid did fill two horns because the septum was incomplete and therefore a subseptate kind of a uterus, which in some cases may have additional pathology, such as a polyp on this one, a couple polyps on this other patient, subseptate uteruses. And here's a sonohysterogram with an unusual T-shaped uterus, patient who had been on DES, mother was on DES, and patient developed a T-shaped uterus and subsequent infertility. Another case loaned from Dr. Leftoff. Sonohysterography could help us out with abnormal positions of intrauterine devices. Here was a case where we did instill a little bit of fluid because it wasn't clear to us what happened with this arm of the IUD. Was it broken? Was it just bent? Turned out that it was just bent and had a little bit of infiltration. Nowadays, using 3D sonography could be a very good way of just doing this without the SHG part. Sometimes you'll see unusual endometrial masses. In this case, it was a soft tissue mass within the cavity, which had a cystic change, and pathology revealed that this was a polypoid adenomyoma, which is really focal adenomyosis tissue bulging into the cavity. Here's another patient, another one with an unusual mass. Both of these had a cystic change within them, but not that that's very specific. And pathology again revealed a polypoid adenomyoma. Another patient with an unusual mass after surgical removal. This was an adenofibroma. Another case here looks almost kind of like a fibroid. Here's a cavity that has little tiny irregularities along the margin of the wall. Biopsy showed that this was unsloughed endometrium related to progestational therapy, and this patient was put on progestin. So we have a little nodular, irregular endometrial thickening in this patient. Here's another patient that had some bleeding, and sonohysterogram showed this little tiny irregularities, which tissue sampling revealed that the biopsy revealed that it was an endometrial polyp with histologic features of progestational therapy, but there was no evidence of malignancy. Now, sometimes we do make the diagnosis of endometrial cancer on a sonohysterogram, even though it's not intentional. This looked just like a thickened endometrium. It looked fairly homogeneous. There was no reason to suspect really that there was a cancer, but once a fluid was placed into the cavity, it was found that there was a very hypervascular irregular mass. This is from Dr. Scout, showing us here a case of endometrial cancer. So even though we don't want to do it, occasionally we may end up showing this at sonohysterography. Postmenopausal bleeding is a presenting sign in 80 to 85% of endometrial cancers. And endometrial cancer accounts for only 10 to 20% of postmenopausal bleeding. So a lot of things out there are not cancer. That's why occasionally we will see it on the sonohysterogram. Most of the time, postmenopausal bleeding is due to atrophy, postmenopausal atrophy, which accounts then for 40 to 50% of patients with bleeding, and their cavities are normal. The blood in a cavity that has endometrial cancer can provide sort of a natural sonohysterogram. We're not placing any fluid in this cavity. This is just bleeding within the cavity, outlining these soft tissue irregularities. Here's another patient that we attempted to do a sonohysterogram, but the cavity was non-distensible. The little bit of fluid that went in outlined a lot of irregularities, so we immediately stopped the procedure, and biopsy showed that this was cancer. Now, that's one of the benefits of doing a balloon inflation, because you can talk about the cavity distensibility. Another benefit of doing the balloon is with the adenomyosis, because we feel that when we distend the cavity with that little extra pressure, that could open up some of these myometrial cracks and help us show a connection with the endometrium. But as far as this goes, with a non-distensible cavity, that could be a sign of malignancy. Here's a couple a few more images of patients with a natural sonohysterogram, meaning that this fluid is blood outlining these very irregular lobulated, usually hyperechoic masses, that is endometrial carcinoma. Again, natural SHGs outlining very irregular, thick tissue in postmenopausal uteri. More samples of endometrial cancers. This was inadvertently, sonohysterogram was done. It's thought to be probably a polyp in there. Turns out to be cancer. So atypical sonohysterographic findings may be seen with unusual polyps, submucous myomas, hyperplasias. Debris, blood clots, mucus strands, adhesions, synechiae give us atypical findings. There's a variety of scars, including Asherman syndrome, C-section scars. There are unusual appearances of congenital anomalies. We talked about these adenomyosis tracts that we're picking up that we either can fill them with fluid, and we believe that we're filling them with some air bubbles. There are unusual endometrial masses that occasionally we can encounter. And at the very end, rarely you may encounter inadvertently an endometrial carcinoma. So I thank you for your attention.